everyone. My name is Dr. Kevin Schafer. I am an orthopedic foot and ankle surgeon at University Orthopaedics. I am joined today by my colleague, expert surgeon, Dr. Justin Fleming, who is also a foot and ankle expert at University Orthopaedics. And today we are going to be talking about Achilles tendinopathy. Justin, we see a lot of patients that come into our clinic with posterior heel pain, and there are a couple of causes of posterior heel pain. So today we're going to spend some time talking about one of the more common causes, and that's Achilles tendinopathy. So my first question, Justin, is let's just talk about tendinopathy. Why might a patient have it, and what is it with regards to the Achilles?
Sure. So I think we probably need to define what tendinopathy is. And just to kind of back up a little bit, there are basically two forms of tendon disease: tendonitis, which we say kind of very commonly all the time. And really, when you boil that down, that is an inflammatory process that occurs around the tendon. And then tendinopathy is really a non-inflammatory process that happens within the tendon. And you can have a combination of both, but tendinopathy really refers to kind of like this chronic intrasubstance or degeneration within the substance of the tendon that generates pain.
I agree 100%, Justin. And I put this slide up here from a textbook chapter, not for everyone to press pause and go through and read all of these small little words, but just to kind of highlight how tendinopathy, it can be different for each patient, and it's not simple. And the simple way to think about it is there are things you can control and those you can't. And there are different areas within each of those that can cause a tendinopathy. Some of them include intrinsic factors. Those are the ones you can't control. Your genetics, your age, whether you have conditions like diabetes, whether you have malalignment. And then there's a family of extrinsic factors. Those are things you have more control over, or things that are not necessarily your fault, right? Injuries, you were doing something and you hurt yourself, or a new exercise routine, you're working out more than you used to. So, it's not the same cause for every patient, and you really have to understand each set of patients' factors to figure out why they might have a tendinopathy. All right, Justin, so a patient comes into clinic with Achilles tendinopathy. There's really two families of tendinopathies that we see. So do you want to touch on that and kind of explain the anatomy and why patients might have certain pain in certain locations?
Sure. So there are kind of two distinct locations that we see it very commonly. One is called mid-substance, and that is really above the bone, kind of below the muscle, right in between. That's commonly where people will rupture their Achilles tendon, but it's really purely tendinous. And then there's a secondary area that occurs really where the tendon inserts into the bone, and that's called insertional tendinopathy. And that usually is associated with changes in the bone, spurring, and changes that you see on X-ray, usually an enlargement of the back of the heel. And those are really the two most common.
Right. Let's spend some time just going to each one of those. Let's talk about insertional tendinopathy. What might patients describe as their symptoms? What do patients commonly say when they come in with insertional Achilles tendinopathy?
Sure. I think there's a kind of a spectrum of complaints really based on how long they've had it. And the number one thing I think that we get is pain and swelling in the early stages. Upon the initiation of push off, or perhaps if they've been seated for a while or after activity, they get pain, and sometimes they get burning right where the tendon meets the bone. And then the longer this goes on, they may complain of swelling that appears all the time, and disability, inability to walk or stand for long periods of time. And then certainly just enlargement of the back of the heel. The heel becomes so big that it has irritation or creates difficulty in the back of the shoe. So these patients often are forced to wear shoes that have no backing, simply just to get comfortable and to get around.
Yeah, it's definitely more visually apparent or obvious in a lot of patients with insertional Achilles tendinopathy, because you can see that large prominence versus non-insertional, although we can see something sometimes that's obvious in non-insertional. So let's talk a little bit about that. What do we see in non-insertional, where patients come in and they tell us about certain symptoms and exam findings?
Right. So non-insertional, kind of within the tendon, the Achilles tendon is typically in a normal patient relatively uniform. And what we may see is kind of this bulbous appearance above the calcaneus, or above the heel bone where the tendon inserts. And the patients will press on it from side to side. But there's certainly, as time goes on, this is a real visual thing that they can see. And most of the time they equate it to swelling, but often it's really a problem within the tendon that generates a secondary swelling.
Absolutely. All right, so the patients have come in, they've given us a clue that they might have an issue with their Achilles. And in most patients, we get an x-ray to get a better idea of what's going on. So Justin, why don't you take us through this and explain why this patient might be having a problem with their Achilles? This is something we see all the time.
Sure. And so hopefully you can see my pointer there, but this is the Achilles tendon coming down in white. And obviously you can see that there's a large spur on the back of the heel. And that's really what causes problems in terms of shoe care. But the pain is typically isolated from the top of the heel to the area around the spur. And patients are very, very symptomatic directly from the back and from the side to side. But
Right.
it is characteristic for long-standing insertional tendinopathy for them to have bony changes in addition to the tendon problem as well.
Right. And sometimes what we'll see is a little bit of a peak here as well at the back of the tuberosity. In some cases, we call this a Hageland's prominence, where you can see a little bit of a spike here. And the theory is that that might rub on the tendon as well. In addition to the tendon kind of turning into calcium, what we call an insertional enthesophyte, sometimes we worry that this area could be abrading the backside of the tendon as well. All right, so we've gone through the x-rays. What patients might we get an MRI? Let's talk about advanced imaging, which a lot of patients will come in with when they see us already, but we order this quite a bit as well. So let's just talk about why we might get this and when.
Sure. So I think an MRI is indicated with an acute event with loss of power, which may indicate that the tendon's been disrupted in some way. And then the second scenario I think that we get it is that they've failed the early conservative or non-operative treatment. These patients have been in a boot. They've had an anti-inflammatory, topical, oral. They've been into physical therapy, which I think is the predominant thing that makes people better. They've done all those things at a reasonable degree, and they're just not that much better. And so if someone comes back to me and they've gone through those steps and they're not 50% better, my threshold to order an MRI at that point is pretty low, because typically there is more advanced disease inside the tendon that we need to know that information.
I agree. And, if they've failed the non-operative measures and you're starting to talk about surgical planning, there's a lot of different things we can do. And the MRIs can give us clues, and we can talk to patients about those different parts of the procedure going forward. And we'll get into treatment in a minute. So let's do that here. Let's talk about surgical treatment and non-surgical treatment. Let's talk about insertional disease first. We'll kind of break these up because both are different. So let's talk about non-operative treatment of insertional Achilles tendinopathy. What do we offer patients, and does it work?
Yeah, well, I think it's largely successful, at least in the short term. The problem with this disease is that it's typically cyclical. People get better, and then you see them, years down the road, and they have another event, and it tends to get worse. But when we first see patients, based on what their pain is. So if they have significant pain, I ask them, are you limping? If they're limping, they automatically go into a boot. And then if they're not limping, maybe we use a rocker bottom sole sneaker like Hoka or some of the other manufacturers. Maybe we put a heel lift in, and by putting the foot in a downward position, we create some slack in the Achilles tendon, which allows it to work less hard. Anti-inflammatories, good old-fashioned ice, stretching, and a supervised physical therapy program. I think that's really where you should start. And you and I have talked about this, but we see patients who have gotten cortisone injections in the past, and I can't stress that enough, that I just don't think it's a good idea to put cortisone in and around the Achilles tendon. And I know you share that belief as well, because the potential to rupture is high. And when you look at the risk-benefit ratio, that treatment specifically, I don't think it's in favor of the patient.
Absolutely. I think that's a great point. I've seen 3 or 4 patients this year alone, both insertional and non-insertional Achilles tendinopathy, who have had not just one, sometimes 2 or 3 injections directly around or into the Achilles tendon. and then have gone on to rupture their tendon entirely. And that's a bad problem, because as you go to fix the tendon in the operating room, a lot of times the tendon is not healthy. So you have to excise a lot of that tissue, and it makes the recovery and the surgery a little bit more involved. So that is not a recommended treatment. Please do not get steroid injections in or around your Achilles tendon. All right, so we spent some time there talking about why you and I don't care for steroid injections around the tendon, but not all injections are created equal. And there's a lot of energy and focus on different things we can inject around tendons to help them heal. What about things like PRP, bone marrow aspirate concentrate? What do we know about these sorts of treatments? Do they work? Are they safe? And is it worth the cost?
Yeah, so those are all the million-dollar questions that you're asking. And, depending on what you believe, you can find literature to support it.
Right.
I would tell you in my experience, it's probably 50-50, whether or not it helps. Is it curative? In some cases, I think it can be. But I like to use PRP in patients that don't have particularly significant disease on an MRI and maybe have not progressed as quickly as we would like in physical therapy. So you have the complexity of the problem is maybe lower from an MRI standpoint, but yet these patients are just really failing to progress. And so, is there an intermediate thing that we can try to try to avoid operative intervention and still give them the necessary kind of biological boost to get them over the hump, to get them healing? I don't know
Sure.
what your protocol or what your thoughts are about that, but maybe you can share that.
No, I agree 100%. I tell most patients, look, this might be a coin flip. I don't know if it's going to help you, but what I do know is it's safe. There's little harm in an injection. And if financially it makes sense to you and you want to try something that's not surgery, because we will talk about how surgery is a long process, then we can certainly try it. But I can't tell you with confidence that it's going to take away all of your symptoms, but it's certainly safe. And in some patients, it actually works.
Yeah. And I do think that it works better in patients that have mid-substance tendinopathy versus insertional, at least in my experience. The PRP is not going to change the bone. It only changes the tendon. And I think my success rate is higher when it's really a tendon-only problem.
I agree. What about for non-insertional disease? Is there anything different that we do? Does maybe the therapy work a little bit better, or is it the same as insertional Achilles tendinopathy?
I think it's pretty similar. I mean, the one thing that I've probably neglected to say, there may be two things. One is a technique called Graston, and that is kind of a specialized therapy that you would get with physical therapy. And the aim of that is to really try to aggravate the tendon to increase blood vessels and heal the tendon. So the primary reason why Achilles tendon problems continue to plague us is that we think that the blood supply may be less and its ability to heal and regenerate is not as sufficient. So that's one technique. And then there's also things like dry needling or PRP, where essentially we're injecting biologics into the tendon to try to enhance the healing capabilities. But I think overall, they are pretty similar in the tools that we have to treat them without surgery.
Yeah, I think most patients have a similar chance of getting better from therapy. What I found, and I'm interested in your thoughts, are the patients who have a very large insertional spur, where it's very sensitive at the back of a shoe or to palpation on exam. Those patients usually don't recover as well from therapy versus someone with kind of a swollen tendon a little bit higher up in the mid-substance of the tendon. I feel like those patients do a little bit better or have a better chance of recovering with therapy. Have you found that?
Yeah, I would agree with that. And there are some really good MRI studies that show, basically looking at the cross-sectional area of the tendon on an MRI, if there's a certain percentage of tear within the tendon, the chance of that being successful without surgery is very low, in the 20 percentile. So I would agree with what you're saying. And I think, as you kind of progress down that road, when you get an MRI, you gather more information about the quality of tendon, but then also, what are the chances of success? Because physical therapy is a time constraint, it's a financial constraint on patients, and so we have to be respectful of, all those kind of life parameters as well.
Absolutely. Well, we've talked about non-operative care. Let's talk a little bit about surgery for this problem and what the recovery looks like and how patients do. So, for these problems, what are the surgical options? What does it look like? How long are you off of your feet? And what is the real trajectory of the recovery? How long does it take to walk comfortably and get back to life?
Sure. So I think that non-insertional or mid-substance Achilles tendinopathy typically has probably a little bit easier course of treatment. And essentially in those situations, we're really removing or excising the bad portions of the tendon and then really sewing the tendon together. We typically use bone marrow aspirations or some other things to increase the biological environment to encourage healing. And I would say that those patients are walking based on the level of the tears, sometimes within 4 weeks into physical therapy. And I feel like that's, usually by 3 to 4 months, they can start impact. Insertional Achilles tendinopathy, when you have the bone and the tendon involved, that's a bit more involved because you have different organ systems. So it requires removing the diseased tendon. It requires remodeling the back of the bone, and it requires reattaching the tendon to the bone. And so when you have all those factors in play, it's just going to take a bit longer. So that's a little bit more of a prolonged course. So those patients are off their feet for 6 weeks, which is not an easy task. And then they're progressing back into a sneaker by 10 to 12 weeks. But really that's, on the order of 9 to 12 months until you're as good as you're going to get. And unfortunately, despite technology and how good we think we're going to heal, that really is a real number in terms of getting better from this.
Yeah, I try to hammer that home to patients as much as I can up front that, this is a 9 to 12 month process where there's going to be some pain, there's going to be some swelling, particularly as you mentioned in the insertional repairs. That just takes time. You're off of your feet for 6 weeks, so you decondition, and then we're limited in how fast we can progress you because the tendon has to heal back down to the bone. So we have to protect it a little bit, and it takes time for you to build the strength and the endurance back in the tendon and the muscle unit. So it really does take a full 9 to 12 months for a lot of patients.
Yeah, not an easy surgery to go through. You have tissue that has disease, that the blood flow is altered, and it's not in a really great area. There's not a lot of, there's certainly no muscle, and there's just a little bit of skin and fat overlying the tendon. So it's a complex anatomical area.
All right. Well, Justin, thank you for all of that fantastic information on Achilles tendinopathy. We really appreciate your time and your expertise. It's been a pleasure spending time with everyone tonight. If you have Achilles problems or any orthopedic problems whatsoever, please give us a call at University Orthopaedics and let us help you get back to a better life. Take care.